जो अशर्स हैं ना उनको ज़रा कहिए बाहर बता दें कि वी आर स्टार्टिंग द सेशन, तो लोग आ जाएं, बिकॉज वो लाइव केस तो 2:30 बजे शुरू कर देंगे. Right, so we'll start the session on time, so it's still, I think, 1 minute left. Ready? So can I ask some of the panelists, local panelists, to come and join us? General Farhan Tayyib, could you join us on the stage? Dr. Tariq Ashraf, Dr. Shaolange, it will be an honor if you could. Oh, you got us. All right, okay, all right. So, Bashir, would you mind joining us so that we can have some panel discussions? Okay, so in this session, the title is Calcified, Undilatable, Uncrossable Lesions. We will also invite our online panelist, Dr. Fahim Jafri from Singapore, if he can join us. Welcome, Dr. Fahim.
I'm here. Good to see you.
We have Dr. Mohammad Agret from UK, and we have Dr. Hakan Ukar, who is in the cath lab, and Dr. Professor Khan Shah Zaman from UK. Welcome, Dr. Saab. And Dr. Afsar Raza, welcome. Welcome to the to the Pakistan Live 2023. You are our online experts, and we have got Bashir Hanif, Tariq Ashraf, and Dr. Farhan Tayyib with us. On the panel, Dr. Shaoling is sitting here as well. Dr. Nasir Samoor Saab, can you join us? So without much ado, I think we should, we are live from Florya Medical Park, Turkey, where Dr. Hakan Ukar is presenting the case. The title is Calcified, Undilatable, Uncrossable Lesions, and it's a combined session of PSIC and Turkish Cardiac Society. So Dr. Hakan, can you hear us? Hello, can you open your audio? We can see you, Dr. Hakan.
Yes, I can hear you. Can you hear me? I think they couldn't hear.
Yes, we heard you for a while.
Can you hear me? I can hear you. I can hear you. Can you hear me?
Yes, I can hear you. This is I'm Dr. Nadeem Rizvi from Pakistan. I'm the presently the president of the society. And we have on the panel Dr.
Hello, everybody. Yes.
Hello, welcome.
Hello, everybody. Actually, first, I would like to say we are very happy, we are very glad to be here with you at that session. Before starting the case, I would like to introduce my team. Dr. Emrah, we have been working for a long time. Erman technician, we have been working for a long time. And also, Dr. Fatih will present the case. The case will be presented by Dr. Fatih, then I will talk about what we have done so far. If you have another question, actually at that time you can answer. Please, Dr. Fatih.
Yes, we are waiting.
Hello, everyone. I'm Dr. Fatih Güngören from Istanbul, Florya Medical Park Hospital. I will present the case now. Our case is 60 years old male patient. He has diabetes and hypertension disease, presented with stable angina pectoris. ECG show us sinus rhythms and ST segment depression in inferior leads. Echocardiographic examination is show us ejection fraction is approximately 60% and moderate mitral regurgitation patient have. We take the patient angiography for coronary procedure. Sorry.
Görüntü. Berat.
Sorry about that.
Berat'a söyle. Çalsınlar.
Okay, so this is a 68-year-old.
Right corner angiography show us the RCA is approximately completed from the mid portion. You see now. And left coronary angiography show us RCA is fulfilling from the epicardial collaterals from the LAD. I will show again. Sorry. Now you are seeing. Firstly, the lesion is crossed with the PT2 wire. This is the first procedure from the first procedure pictures. The lesion crossed with the PT2 wires, you see. And then after the wire spaced and the lesion couldn't cross with the low profile balloon. And then it was decided to take reintervention with rotablation procedure. Now this is the second procedure. Thanks for your attention.
So, Dr. Hakka, this procedure was done previously. When was this done?
Yes. In the last week, the patient presented with chest pain, and we performed the angiography. Then, as Dr. Fatih said, we tried to cross the lesion, and we crossed the lesion with luminal with a guide wire PT2. Then we tried cross the lesion with balloon, but we failed. Actually, we failed. Then we used a lot of balloon, small profile balloon, 1.0 small profile balloon, but we couldn't cross the lesion. And we saw there is a heavily calcified lesion, and we decided for this patient. This patient is uncrossable, maybe undilatable CTO, an early CTO case, nearly not almost a totally CTO case. Because of that, we decided for the other device, like a rotabulator system.
Can I just interrupt you and ask? And can I ask the panelists that if you can cross the wire, how many times have you been unsuccessful in crossing with the present balloon? Dr. Hanif?
It's not that common, but definitely we do see, especially in calcified lesions, we are able to cross the wire and the balloon may not cross. A lot of factors are really could be contributing to that. Most important one is the support from the guide. That is the most important thing. And obviously the balloon, what kind of balloon you are using. Now we have very small, very good profile 1.0, 1.1 or 1.2 balloons which can be used. Or you can use anchor, and if it's severely calcified vessels, then if all these maneuvers fail, then obviously that means that you need to do some atherectomy. There is significant calcium over there.
Right. So, Dr. Hakar, my question is, why did you not go ahead with the rota at the same time?
Actually, after the way we couldn't cross the lesion, we don't have every time rotabulator system or lab. Because of that, when we see it will be hard to cross the lesion, because of that we decided to arrange all of device. Because of that we delete the case for today. Now I know when you face these cases, you have two options. One of them is increased support, and the other modify the plug. For increased support, maybe we could use anchor technique or guide extension catheter, or maybe we could change our catheter with big size or another guiding catheter. And to modify the plug, we should use rotabulator systems, sometimes IVL. Sometimes you can use a different technique, for example, granuloplasty technique. Because of that, actually, we prepared the case for rotabulator, Rotapro system. Now, after your comment, actually, I would like to talk about what we have done today. Then I would like to start the case.
Yes, please, go ahead. Dr. Fahim Jafri, any comments?
Nadeem, I think that the operators have done exactly the right thing. So if you're not able to cross a lesion with a small 1O balloon, you know that inevitably, in order to get good expansion of the stent, you're going to have to modify the plaque and probably need to use ablation. And if it wasn't available at that time, rather than try to keep pushing and then end up dissecting the vessel or losing flow, the right thing to do is to stop, get the equipment you need, and then go back in. So I think they're doing exactly the right thing. And the key is to modify the calcium in such a way that you're able to not only expand the lesion, but then put in a stent safely. So I think this was the right thing to do.
Okay, thank you very much. Dr. Hakar, you carry on.
Can I echo that, just to say that it is really important cases
Yes,
like
Mohamed.
this is not to push on and try to do the case without preparation well, because you keep pushing and take a bigger balloon and a bigger balloon, and you end up putting a stent that's under expanded, under deployed, and you only run into trouble. If you think you need rebulking, rotablation, or laser, or orbital atherectomy, whatever it is, do it, because you save time. You make sure you prepare the artery and the lesion well, and you guarantee a good long-term outcome, rather than just pushing on with your balloon.
Thank you, Mohamed.
Yes.
You carry on, Dr. Hakar.
Yes, yes. Now, I would like to show to the images. Please go on. Go on. You increase it. Now, as you see here, there is a total occluded lesion. I think it's because of the first attempt. Actually, we crossed the lesion easily with PT2 guide wire last week. Now, then, this is the dual injection imaging. There is a good epicardial collateral from LAD. Then we used the right radial artery and we placed cylinder sheet 6 and 7. Then we advanced 7 French guiding catheter. As you see, we did anchor with 2.50 millimeter balloon. Actually, then I start to cross lesion. I thought maybe I will cross the lesion easily because of I tried actually with pilot 50. Then, please. And as you see, it was very easy to cross the lesion because it's the new closing. There's a new closing. This is the pilot 50. But then I tried to cross microcatheter. Microcatheter is Pro XS, or say Pro XS, but I couldn't cross. At that stage, I would like to ask you what option will be better for this patient. Maybe we need to change with another microcatheter.
Okay, we've been joined by Dr. Salman Arai. Welcome. Can you make a comment on this? If you can't cross with a microcatheter, what would be your next step?
So, no, I think this is actually a good point. The big challenge is obviously support at this point. And you have a wire in the conus. I think this is a good setup for anchor technique. So I would anchor that and see if you can go ahead and just drive the catheter down by torquing it. Sometimes that tends to work. If that doesn't work, then you may need to do granuloplasty or something, some prep up front, maybe get a guide extender deep into it. So you just have to build support, and hopefully the catheter will then cross.
We have seen like sometimes even the rota wire, you try it, sometimes it goes, you can try, I'm not saying it always goes, but sometimes that actually crosses without any other like microcatheter or something.
I think once the wire has crossed, it's very hard to pull it back.
The new rota drive wire is really good. It can sometimes you can bare wire your way through this, not through a CTO like this, but if it's a very tight lesion, sometimes you can just cross with a bare wire. But the newer rota drive, not the old one.
I mean, the excess support rota wire also can cross. I was going to say, I mean, probably the better choice in here would have been an AL1 guide, because now with the anchor balloon, trying to push the rota burr, because you are planning on doing rotablation, might be a little tricky. Might be quite difficult to kind of pass it through with the balloon inside the catheter.
Mohamed, that we should have a better guide score.
Dr. Afsar Raza?
Yes.
Yeah, actually our plan is that if we can cross the microcatheter, then we need to change guide wire, workhorse guide wire with rota guide wire. But we couldn't cross. No, at that stage, actually, maybe we can try with a small profile balloon to cross the lesion, and if we dilate the lesion a little, then we can cross the microcatheter easily, then we can change the guide wire.
Why not using the anchor?
Sometimes you can actually shove the microcatheter in the lesion, pull out the wire, and then just put a rota wire through that, and you're surprised how many times it'll go successfully.
Also, this is a Corsair Pro XS, which is not the most robust of body. So maybe changing to a turnpike spiral, or even the Corsair Pro itself. The Pro XS is a little between the Caravelle and the Pro. So it's not as robust. That's another option. But you're absolutely correct. Maybe putting the microcatheter into the lesion, trying with the rota wire might work very well, because the Pilot 50 went easily.
Yeah, you're right. Maybe we can change with another microcatheter, as you said, like Corsair, normal Corsair, or maybe turnpike Gold. Sometimes you need to use Turnus microcatheter to cross this lesion. Actually, our plan is before to use a minimal small profile balloon. If we fail to cross the lesion, then I will change our microcatheter with another one. Bir şey alalım geri, microcatheter.
Right, so I think the turnpike LP is a good choice because you can torque it forward. The Caravelle, you can't torque as much.
Yes, Salman, this is my question to you, because we've been discussing this on the master forum. How much difference is there between different microcatheters? Like we have fine cross, super cross. Super cross is terrible in crossing. Fine cross is better. We've just got Caravelle, but it's a bit expensive. What about the crossability? Which is the best one to cross?
You know, so my personal style is I use a lot of torquing. I actually spin the wire, the catheter quite a bit.
Which one?
I spin the catheters quite a bit. So I like something that I can torque. And so for that, either the Corsair or the Turnpike or the Turnpike LP tend to be, because they have a second coat of nitinol wires.
The profile is the same for each one?
They're all about 1.4 at the tip, and then the difference in how much they taper up. But the lowest profile is the Corsair ES or the Turnpike LP.
Right. Okay.
But I think here the issue is support. I mean, while rota is a good idea, I would still try anchor first. Try anchor, then granuloplasty, then maybe you think maybe. And also because the Corsair or the catheter is getting stuck quite a ways down the RCA, and that's an opportunity. Because then, like gentlemen suggesting, you can actually build up the proximal portion, even go with a 1.52 or 2.5 balloon, and then you can deep seat the guide or get a guide extender in there. So some opportunities here.
Right, Dr. Hakar? So tell us, what is your plan?
No, our plan is to use small profile balloon. Then if we failed, actually, I would like to use another microcatheter to cross the lesion.
Yes, my favorite...
Mohammed, maybe I can ask you, what about laser? We don't have it in our practice.
Actually, I know when you fail to cross the lesion with microcatheter, you should use the laser. Actually, but we don't have laser, you know.
Right, okay.
Yeah, I mean, this is a typical... this is a very good indication for laser and crossable lesion. Even if it does not cross the lesion completely, just by applying the laser at the proximal area where the resistance, it changes the complexion and changes the tissue, and then you'll be able to pass it through. And sometimes you have to do like an inchworm, where you use the laser, then the balloon, then the laser, then the balloon until you cross the lesion. So certainly this is a very good case.
I think that's a good point. And I don't think you can say it's uncrossable when the guide is hanging out. Right. You say it's uncrossable when you have good guide support, and then it doesn't cross. Then it's uncrossable. Right now, we still don't know if this is uncrossable or not, because the guide is hanging out. So you need more guide support.
But this was my point about the AL1 and avoiding the anchoring balloon, so you have enough space to do whatever you want. Because with this anchor wire and balloon in, probably if you try to use a guide extension, it will not pass any further than where the branch is. So there is a case of changing this guide and putting an AL1, recross, and if you need to use a guide extension, it'll go down to the legion, so you have a really quite a good support.
Yeah.
If the wires,
I think
The
Mohammed,
extension catheter will support us. Maybe we can use the guide extension catheter also.
yes,
Mohammed, just
Dr.
a small
Fahim.
point. I mean, not everyone has your skill set, and people who are watching this should also understand that while AL1 is very supportive, it is also quite dangerous. And so, for me, I mean, I would always recommend using, something like an Ikari with a guide catheter extension, anchor to get something across, because not everybody has the skill set to manipulate an AL1 safely and without dissecting the osteum and end up with an aortic dissection.
Sure, I mean, that's a valid point, but it is not dangerous. I think JR4 can be dangerous. It's how you handle it. And of course, it does take a little bit of experience and use. My point about this, because you have the anchor and the conus branch, anything you're going to try to use like guide extension is going to stop there, so you cannot have enough support to go down to the lesion.
Yes, I agree. I think
And
this
you're
sport is
absolutely
very
correct.
crucial.
Yeah, if you take that anchor and just guide extension into the lesion, then that might be better.
Yes, in Pakistan, the poor man's way that I would do it is to use a JR4. If the wire crosses so distally, just put the JR right down to the lesion. You just anti-clockwise and push it with the right hand, and it usually deep intubate it. And that's the poor man's way of doing it. But I think I agree with Dr. Salman that you can't say it's unless the support is good. And I think the point that Dr. Ahmed made is very valid, that if you got two wires there, one in the conus, you are not going to get the guide extension down. So, Dr. Shahzaman, any comments from you?
Well, I think it's mainly a guidance and support which is very extremely important. And I can see that, perhaps the wire has crossed, but lesion is too hard and rotablator may or may not succeed. But I'm not very convinced with the guidance support which I could see on the screen.
Right, Dr. Hakan, can you tell us what you're doing now?
Actually, maybe you saw we crossed the lesion with anchor with 1.0 50 millimeter Artemis balloon, but the balloon ruptured. Was ruptured. Now I changed another balloon.
So they've
I will
crossed
try
and
again. I will
ruptured the
show
balloon.
you the images.
So they've crossed and they've ruptured the balloon, 1-0.
Yeah, as you see.
So I would angioplasty there and then maybe rupture it there?
Yeah, they crossed the balloon.
Maybe.
At 16 atmosphere, the balloon ruptured.
No, but the new balloon is getting stuck again because the guide is pushing out.
Yes. Yeah.
Yeah, just angioplasty.
Yeah, as you see, we crossed the lesion. This balloon is 1.5, 10 millimeter rear balloon. Okay, rear balloon. Yeah. 16, okay. Yes. 16.
Is this a compliant or
After balloon, actually, I would like to use rotational atherectomy because there is, as you see, there is a calcific lesion. Okay.
So was this a compliant or non-compliant balloon?
Yeah.
1.5, I think it's semi-compliant. I don't think you have.
This balloon is
Do you have non-compliant in 1.5? I don't think so.
1.5.
Yeah.
Yeah, we do. Yeah, there's a non-compliant 1.5, yes.
Oh, right. Okay. It's not available in Pakistan. I've been asking for 2 millimeter non-compliant and we can't get it.
No.
How many in the panel has experienced perforations by using 1.5 at high pressure in such a lesion? You bust the balloon and get a perforation in the right. Does that happen often? I haven't seen it.
With
Not really,
1.5,
no.
I
No,
haven't
really.
seen with that small
I mean,
balloon.
I,
Çok basitleri alalım.
in a way, this was I was asking about compliant, non-compliant, because 1.5, this is probably a 4O vessel easily. And 1.5 at 16 atmosphere, it will create a channel, allow you to, but sometimes it might not. So you might have to go to a bigger balloon. But yeah, 1.5 in high pressure very rarely will cause any problem.
But before I started with
going on order.
1.0, 50 millimeter Artemis balloon. Then I took another balloon. Yeah, okay. No, I will use microcatheter again. I think it will cross easily. Then I would like to change our guide wire with rotawire. Then
So
I would like to perform
in the
rotational
panel,
tape for this case.
I'd like to ask the panelist, how many at this stage would then shift over to rota as compared to now just going ahead and using a higher balloon and probably, maybe an IVUS and stenting directly without using how many would just try a non-compliant balloon?
I think, Nadeem, it depends on the visual, because we can't see clearly the calcification. So what is the visual assessment of the calcification? It all depends on that. I think if it is visibly calcific, and I think you should straight away choose the rota rather than trying balloons.
To my mind, it's always, if you think you need the rota, go ahead and use it. Because you never regret it. But you may regret if you don't use it.
Yeah, I would echo that and agree with that. I mean, you know this is severely calcified. You know it took forever and a massive effort to cross this. So just go ahead and ablate a 1.5 burr, won't do much harm. And once you've ablated some of the calcium, then you can image and see what else you need to do. So I would not use a balloon and dilate this further.
Yeah, I think I'll agree with my other colleagues as well, that here I think rota is definitely required rather than just keep on ballooning, which may end up in, not properly stented vessel.
Yeah, but as they seem to be having this problem, you see, it's not easy with all this disrupted calcium to get this microcatheter across.
No, but can you anchor and do the microcatheter just the way you did with the balloon? If you put the anchor up, your microcatheter should cross. Yeah, seat the guide anchor.
I think he already has the anchor, doesn't he?
Yeah, we have our anchor.
It's just the catheter not giving any support.
Push the guide, kind of make it implants.
I think the problem is the support.
I mean, the other option is to try to get the rota wire, at this point, you've got the catheter fairly distal, see if the rota wire will go, and that might just solve the problem. But then start off with a 1.25 burr if the microcatheter is not crossing.
No, but why I think that's good, but why uncross the lesion? Why not try 2.0 first and build some room up? Because I just don't like uncrossing a lesion after it's been angioplasty. I mean, maybe it's going to be okay, but why take that chance?
So, Dr. Hakan, the suggestion is that why don't you use a bigger balloon to make a bigger channel?
With microcatheter, actually, I don't want to open another microcatheter, and I will use another balloon, 2.0, a big size.
Yes, that was what the suggestion was, to make a bigger channel so that the microcatheter opens up.
I can hear you.
Why not try the rota wire directly?
Someone was suggesting why not try the rota wire directly now.
Yeah. No, I would like to use rota wire, but before I need to advance microcatheter. I will change or guide. But if I couldn't, that maybe we can try to cross. We can try to use rota wire. Maybe it will be advanced easily. I know. Maybe we can try that. All right.
I think if rewiring is not a big problem, then I think probably considering using a guide sport like Ambulance has, Mohammed has said, is probably a good choice.
Yeah. Rota telini açalım belki izi kolayca gider. Yes, I will try also rota wire. Maybe it will cross easily.
After the 2.0 balloon, maybe try the rota wire alongside it.
I will balloon with a big size.
Yeah. I think the AL1 guide ship has sailed because right now the wires are crossed. You just need to make this work. Because at this point, I think you're close to succeeding. But to the question about the rota, I think it also depends on your resources. So in the US, for example, for us it would be quicker and more efficient to have rota and get a more reliable result.
Though sometimes you just maybe try sequential angioplasty.
Yeah, just Fahim, your thing about the new rota wire. Can you tell us something about which wire is this, the new rota wire? Is
So
this more easily
it's called the
crossable?
Rota Drive. We've just recently got it. It's been available in the US for quite a while. It's made, actually, Asahi has been involved in that technology, and it is much more steerable, many orders of magnitude better than the old Rota wire. The old Rota wire is impossible to manipulate. That one, I mean, we bare wired and crossed many cases, including, one we did, the live case we did this morning. We just crossed it directly with the Rota wire and were able to get it distal.
But it comes in a package. It doesn't come separately. You can't have it separately, can we?
I mean, it comes as part of the whole Rota thing. So, I mean, instead of the old Rota floppy wire, we use the Rota Drive now. And it's, as I said, it's made with Asahi's collaboration, and it is many-fold more steerable. And, as I said, we were quite impressed by it.
Fine alabiliriz. Fine cross alabiliriz.
So this is with the new handheld Rota, the new Rota device?
I will change our microcatheter with fine cross. I think fine cross will cross easily. I performed with another balloon, 2.0, 50 millimeter rear balloon.
I mean, why do you think? I mean, is it worth now after the two balloon trying the Corsair again? Because the Corsair you can spin it.
I don't want to try again Corsair Pro XS, and I know I am using another microcatheter, fine cross microcatheter.
So they've already opened.
You cannot spin it. That's the problem. If it gets stuck, you cannot spin it.
Yeah, you have to be careful with fine cross and Caravelle. You spin it, you end up leaving the tip.
I know.
There's enough channel now for the fine cross to go.
But I think the 2.0 balloon went, so I'm hoping the fine cross should go. It's also not as flimsy as some of the other catheters.
Dr. Hakan, you have, unfortunately, we have 10 more minutes for your transmission because we have to go over to another transmission. So just to preempt you, we're very interested in seeing how you manage it.
Okay.
Yeah.
Okay, thank you.
So remember, in Pakistan, the problem is not only the inventory, it's also the resources. Each microcatheter costs around 85,000 rupees. And of course, if you're reusing it, that's another issue.
You can use an over-the-wire balloon in this situation.
Yes, but they're not very readily available these days.
I think the problem with the over-the-wire balloon is the same thing. It will not cross so easily if your 1.0 balloons are not crossing. So
the microcatheter fine cross has crossed down to the distal vessel, so they're just about to exchange.
It flew across, very nice.
So the strategy, again, coming from the panel, Dr. Nasir, Dr. Farhan, can you make comments? I mean, what is your sequence of crossing a lesion which is not crossable?
We crossed the lesion. Can you hear me?
Oh. Yes, we've seen they've crossed the lesion.
We advanced microcatheter, fine cross microcatheter. Now we are changing our guide wire with Rota guide wire.
Yeah.
Then we will start rotational atherectomy.
Right. Yeah.
Okay. Go ahead. Okay, this is the guide wire, Rota guide wire.
Right. So among the audience, does everyone have access to Rota wire in the city at least? If you don't have for example, in KPK, how many Rotas are there? Saeed? Yeah.
Yes.
Right, but there's one in Peshawar, one in Saath. All right.
Okay.
I think we have to see that if there's a lab where his Rota is available or there is a lab where the Rota is not available.
Yeah.
both labs will have different strategies. The one who does not have rota, you have to use balloons, progressively bigger balloons, and ultimately achieve a result. On the other hand, the labs which have got rota, modern techniques like IVL, then of course you plan for rota first. You cross a wire, like in this situation, then create a space for the rota wire to be placed.
Does
over the
anyone
wire
have
balloon or
IVL in
microcatheter.
Pakistan? Do we have IVL here anywhere?
We do not have IVL in Pakistan, but we're just talking of rota.
Yeah, yeah.
I think
But we do have laser in AFIC. Laser can be used in such situations.
So none of you are going to use cutting balloon as a sequence of...
Cutting balloon is very difficult to track. I mean, these balloons were very difficult to track. They got burst.
Right.
So cutting balloon will be very difficult to get through.
just one point that I would like to add, that in our situation where we have limited resources and cost is an issue, I think the first thing, especially in this sort of a planned case, is to have a good guide support. I think that would actually, in a lot of cases, you might actually get away without using a lot of the equipment that is being used. But if even with guide support, with anchoring, you cannot get in, then obviously guide extension would be an option, or torqueable microcatheters. I think that would be the way to go about it. Granuloplasty is another option. If you can't get the balloon through, you use a smaller balloon and do a granuloplasty, and then try to progress the balloon.
Right, Dr. Hakan, are you now crossing?
Actually, when the patient has a really calcified lesion, I know we should perform a coroner imaging, IVUS or OCT. Then we need to decide which device will be appropriate for this patient. I know that, but I think the IVUS catheter will not cross the lesion easily before. Because of that, please.
So can I ask what burr size are you using now?
Burr is 1.5 burr.
Are you planning on just doing 1.5, or are you going to upgrade in a large artery such as this?
Yeah, maybe, but I think the size of the vessel is 3 or 3.5 when you look at from the retrograde. This size, I think, will be appropriate for this patient.
Because often this is quite an important thing. A lot of rotablation take place with a small burr, and you find out that you do a 1.25 and 1.5 in a 4.0 vessel, and then you still struggle thinking that you have done rotablation. Preparing the vessel well is quite important.
That's right, the preparation.
Not necessarily in all cases, but just because I think this vessel, when you IVUS, it's probably going to be a 4.0 at least.
Yeah. After rota, I will perform IVUS. Then I think after IVUS, we will decide if the patient needs another device. Maybe IVL, the patient will need IVL. Shockwave.
Yeah, I mean, that's a good point here. That's what I was going to come to. Of course, sometimes, some cases, you do need to calcium modifying technique, such as rota and IVL. But that adds to the cost hugely. And this comes to the point about using the kind of, probably the 0.6, 0.7 of the vessel burr size. For me, if the 2.0 has cost, I probably would have gone with the 1.75, one burr, once and for all, and then gone away with it. But 1.5, you might still need to use the IVL. But as I said, that adds to the cost. And it's been happening a lot where you use 1.25 small burr, and then you take the IVL, which in some cases is very needed, especially in deep calcium. But for cost saving, might not be the best option.
Yes. Sometimes you can use hybrid algorithm. Sometimes you use the rotabulator, but you can see it's not enough for the calcified lesion. If the patient especially has deep calcification, deep circumferential calcification, you should use IVL also. It depends on the patient situation, yeah, right.
And I take it this temporary wire because of the rota, right?
Yeah.
Do you still use temporary wire in all your rotablation? I mean, right coronary artery or dominant circ?
Yeah. No, we will advance the Rota Pro system with dynaglide mode.
How about any guys in the panel? Anybody still using
temporary pacing wire? In traditional teaching, Mohanad is to use it. I haven't now. I've stopped using even if the patient becomes bradycardic, it's not a big problem unless you do long rota. So I've stopped using temporary wire. What about the rest in the panel?
Yeah, we don't use temporary
We
pacemaker.
don't do it routinely. We will sometimes use IV aminophylline, but pacemaker is quite uncommon for us.
Yeah, we do the same. We keep IV aminophylline there if needed. We will give them.
Now we are removing anchor balloon and wire for rotablator.
The only thing I did not, is this a 6 or 7 French?
I think looks like a 6
Seven,
French.
seven French, seven French.
Seven. Yeah.
Because even with 7 French, the presence of balloon or another wire with rota could be a little tricky.
Oh.
So I think we've got about 2-3 minutes. We are going to see the first rota run, and I'm sure they'll be able to do a very good job, because once the rota modifies the plaque, then IVUS, and then further rota or stenting with NC. So I think the teaching parts have been covered in this case. For an uncrossable lesion, we've seen the problems with kite support and with other things. So we're just going to see the rota.
I would like to talk about the Rota Pro system. You know, there are 3 components of the system: console, advanced system, and BER. BER is connected to, advanced system.
Are we ready?
No, you carry on. We've got 2 minutes.
Can you hear me? No, yes. Now we will advance, advancer, and when you decided to advance the system, you need to defeat the brake to move easily. Then we will advance advancer system interguide. Yeah, please.
Okay, thank you, Dr. Hakan. I think
Yes,
I'm sure you'll do a good job. I think the next cath lab is waiting, and so because of an interest of time, I think we need to switch over. You carry on, and we'll keep on seeing you until we are cut off. Our next case is from UK, and it's Dr. Javed Ahmed from Freeman Hospital, and Dr. Asad Akbar is going to take you to the case.
Okay. Yes.
Hi, Dr. Javed, can you hear us?
Yeah, I can hear.
Yes, so we are live now, and we have a very esteemed faculty here, Dr. Nasir Samoor, General Farhan Tayyib, Dr. Tai, Dr. Tariq, Dr. Bashir Hanif, and Dr. Salman Arai are all in the panel, and a fully packed audience. So please go ahead and tell us about the case.
Thank you very much, first of all, for inviting us to participate Pakistan Live 2023.
Okay.
And we are grateful to the organizers. Okay. I got my colleagues here with me, and Dr. Bilal Bawamia, who is one of our consultant colleagues, and another of our colleagues. And I got Emma, who is one of our senior nurse, and Olivia and Joji. So that's our cath lab team for today. The case we have got is a 75-year-old gentleman who has been having frequent episodes of angina. He cannot even walk to the car park without having any symptoms of chest pain. And he was referred from a peripheral hospital where he had his angiogram by the right radial artery. And today, when we were planning to obviously start the case, he has got no right radial palpable. So that's why we decided to go by the right femoral artery. So that is our approach in terms of getting access to the coronaries. And this gentleman also has been investigated for weight loss, and he has got no other comorbidities such as angina or hypertension. He has been discussed in MDT, and the consensus of opinion was to treat with percutaneous core intervention. The angiogram which was performed at the peripheral hospital at the time, there was not good engagement of the right coronary artery, and it looked like whether he had got an ostial, severely calcified right coronary artery lesion with the tramline calcification of the whole of the right coronary artery. And then there was also tramline calcification of the LAD as well as possibly of the left main stem. So we initially decided that perhaps we will do intervention on the right coronary artery. But again, today it appears that when we did the initial picture that the right coronary artery is almost completely occluded now. And obviously, the next target was the proximal and the mid-LAD, which is severely calcified along with some left main stem. So we decided to obviously image it up front, and the LAD was wired with cyan blue wire, and after that we also wired the circumflex, and we decided to do the upfront intravascular ultrasound, which we can put it on the screen, please.
Javed, can you show us the images first, the coronary angio, before we go to the
Okay,
IVAS?
could you show the angiogram first, please? Huh? Yeah. I think Bilal will go through with the angiogram.
Can you hear me okay? So this gentleman had also...
We can't hear him.
We can't hear you very well.
Can you make the volume up, please, a little bit?
Can you ask them to do...
Javed, you go ahead and show us the angiogram while he's sorting.
Yes, can you just show the angiogram here? The angiogram, the coronary angiogram. So this is the left-sided angiographic pictures today with a diagnostic catheter. This is not a guide catheter yet. So when we actually engage into the left main stem with a diagnostic catheter, there was pressure dampening and patient had some ST changes as well as chest pain. So we just did this picture right at the start, and then we decided to engage into the right coronary artery, which we did not selectively engage. Can you just show the picture of the... And we thought the artery has now been completely occluded.
Next one.
You can see a lot of calcification anyway in the subsequent images.
Keep going, yeah. So, I mean, at this point, I mean, the patient, after the injection of the left system, he became, I mean, ECG ischemic. So we thought we had to proceed to sort out the left system. So we just wired the LAD and the circumflex and kind of backed the guide out. His pressure improved at the time. Just keep going there, please.
I think at this stage...
The picture was very small. Where is the lesion in the left? Can you describe the lesion, please?
We will come to that in a minute. One important thing, we did debate that we should do upfront rotablator. That is usually my strategy. If, for example, if you're not going to use the rotablator, then use it upfront and...
Sorry, can't hear you.
Can you not hear me now?
Just go back, yeah. Go back.
Can you hear me?
No, we could hear Bilal. We can't hear you very well, Javed.
Could you just...
yeah, that's better. That's better.
Okay. So basically, we thought we will do upfront rotablator, but it did not give us any time to consider that because the patient became ischemic with some ST segment changes after the IVAS, which can happen after the IVAS catheter because it usually impedes flow. And we decided to go ahead with the balloon at least to establish some flow and then plan a strategy from there on.
So
I mean, obviously...
Sorry, where was the lesion that you thought you needed to balloon? I'm not seeing that.
Yes.
Is it left main
I
or...
think that's what I said. We will come on to that. Can you just put the IVAS, please?
But Javed, also, what's the LV function here? If we're thinking there is a occluded right coronary artery, and you are going to rotablate the left system, there's always that potential of no flow or problem. What's the LV function like?
LV function is normal.
Right, okay, so the right coronary artery is viable.
Yes, I think that's what we were trying to start with the right initially.
Yeah, but this does put in a
To
somewhat
be some
more
distal
high
left
risk.
main lesion involving the ostium of the circumflex.
Could we just show you the IVAS? That is very important. If we could put the first run, please. Yeah.
So if I can just describe the lesion
Because as you mentioned, there is a damping of pressure, so there must be some left main lesion somewhere.
So, yeah, exactly. That was our worry, actually. There was a significant osteal left main. So that's why we went for the IVUS. And the IVUS initially went through the left main into the proximal LAD, but it wouldn't cross the proximal to mid significantly calcified LAD disease there. So I don't know if you can see on this single angiogram there, the PA caudal, that there's actually a significant calcified lesion proximal to mid LAD, which goes across this big septal branch. So the first septal branch actually is providing a lot of collaterals to the distal PDA. So at this point, our thought process was whether there's a significant osteal left main lesion that needed to be treated. That's why we started with the IVUS. The IVUS, I'd say, let's just play the IVUS now, please.
So, this makes it an interesting lesion now because now it's a more high-risk situation, right? It's a short left main. Anything you do to the left main is going to occlude it, and without an RCA, you're occluding essentially the entire flow to the heart. So, again, it makes you wonder if you need more mechanical support up front, or at least be psychologically ready for mechanical support should you need it.
Yeah, the points about it is well made, actually. We did think about that up front. If you look at his femorals, I don't think it's very attractive to put an impeller in, for example. We had our TAVI fellow who's very skilled in getting femoral access, so he managed to actually get into the left femoral artery and successfully. But I think it would be a good option. But I think in that case,
on the IVUS, it looks more osteal LAD, or am I
No, that's what I was going to say.
It's not the osteal left main.
There is some eccentric calcium in the left main, and maybe the guide how it's sitting, Fazila.
But when you treat the osteal LAD, you are going to be occluding the left main, right? It's not a very long left main.
No, of course. That I'm just trying to localize the lesion because if you look at the angiogram in that on the right side, you don't see anything. But clearly something happened because he became very unstable.
It's eccentric, isn't it?
I think another thing is this on IVUS, which we're going to put it now, that's what we have been waiting for. There is no significant left main lesion. So I think that was a good thing in our favor. However, in the LAD, the magic number of cross-sectional area, particularly in a male, and should be at least more than 5.5 a minimum. It wasn't. It was quite a sort of a reduction in the cross-sectional area with the calcification at least 280 degree. Could we put the IVUS, please?
Yeah. Would you consider pressure wire with like a pullback? So I think IFR with pullback would also help you localize the lesion. So something's ischemic, and you can see if it's a diffuse gradient or if you have focal
Could we just show the IVUS, please? Can you see the IVUS on the screen?
Yes, we can.
Okay. So you could see that there's already a calcification, which is, you can say, is about 270 degree, sort of, as long as we travel from distal towards the proximal segment of the artery.
What is the area of stenosis? Can you show us that, please?
It's very tight.
Can you stop there? Yeah.
So this is distal left main. So I think you clearly see the other wire coming in.
There we go.
At the ostium, it's almost like 360. It's about 270 to 360 just at the ostium. So it's pretty concentric. This...
There's another area, Bilal.
No, I think it's definitely tight. I think there's no argument there. I don't think anyone would fault you for
saying that's right there.
Tight.
Yeah. I think there's quite a bit of calcification. And in fact, even when we touched the artery with intravascular ultrasound, there was absolutely no flow. Yeah. And that itself an indication, the plaque burden along with the calcification, that was a contributing factor. Yes. So I think at that point, our preference was to actually, first of all, to rescue the artery, at least to start with a balloon. And then obviously, once we have ballooned it, there are going to be some micro dissections and all these sort of things. I prefer not to do rotablator. And then we went down the route of another calcium modification strategy, because for any lesions nowadays, lesion modification and preparation, these are the two single most important factors, particularly when there is a lesion are more than 200 and let's say more than even 230 degree arc of calcium. Yeah.
I think the conundrum here is that the lumen is kind of too big for rota. On the other hand, if you want to use IVL, the problem is going to be the tolerance. If the guide made him sort of tank, then if you put an IVL or even a balloon for a few seconds.
That's a very good point. And that's a very good point. And what we decided to do, we decided to go with IVL 3.5, and that wouldn't go. Obviously, IVL is a bulky balloon, so we have to put a guide liner, and then through the guide liner, we partially delivered the IVL balloon and into the lesion, and we could show you the way the lesion was underexpanded. Could we just show the angiogram where we actually have a 3.5 balloon in the lesion?
Javed, can I just ask? Sorry, I mean, my concern would be that in terms of when you're thinking about this case, if he became so unstable with a guide, then any balloon, and particularly in IVL, where you have to be, up, the balloon has to be up for quite a while. I think that the point that was just made about mechanical support is very valid in this particular case, or consider an alternative strategy.
I mean, one thing to say here, you don't have to deliver all the pulses. When you're using IVL, you could only deliver 5 for 5 seconds. You don't have to deliver the 10.
Yeah, that's a good point. That's quite true. That's a good point.
We get kind of fixated on this. But just to take Javed on what he said, I don't want the message to be going out that if there's dissection, you can't use rotablation. You can't use in big dissection, fair enough, if there's a big flap. But usually, we do use it in CTOs and subintimal space. You can still, with micro dissection, still use the rotablation. But obviously more safe with IVL.
Mohammad, can I just show that this is a 3.5 IVL balloon after 60 pulses? It is still not expanded. This is the angiogram, which obviously we have put. I think. Can you see that? So you will see there is a huge amount of under expansion at the body of the balloon between the two markers. You see.
And Javed, this is quite often what we see when there is not. Usually 270 degree of calcium, you should have the IVL very effective. But quite often, this is the cases where it's not.
Now you could see this IVL balloon now it is fully expanded, almost when we are about to finish all the pulses in the catheter. Yeah. So we managed to obviously expand the proximal as well as the mid part of the lesion. You could see a lot of calcification. And then obviously after that, we decided to do some further dilatation with what we call it a non-compliant balloon. I think obviously generally what I usually do even after the IVL to make absolutely sure that your stent has got an easy passage to the lesion and the delivery becomes really easy, then perhaps it's not a bad idea to use an NC balloon after using an IVL balloon. I think that's what we did.
Yes, NC or sometimes
we can also now, I think Bilal pointed out, we can also show you the IVS after the IVL. Then you could see the difference in, and you could see some obvious cracks.
Sometimes when you have nodular...
How did he tolerate the IVL? Did his blood pressure stay okay? Did you have to use inotropes or?
I think...
I think that's
fine.
He
was fine. He was fine when we were actually doing the IVL. And I mean, there was some shock topics, you see. Apart from that, I think there was nothing major. And because we managed to...
Because you would distal to the circumflex. You see, the main thing is that the problem would have been if you had covered the circumflex, but without covering the circumflex,
can you see the IVS now, please?
Okay. Yes, and we can also see the fracture lines in the calcium.
Can you put the IVS right from the start? Sorry, Bilal.
So, can we put the NG on the main screen, please, maybe, and then IVS on the side screen once you are done with this run?
I think, so this is the run of IVS after the IVL, 3.5 IVL. You could see that there was almost 270 degree calcium. There was some cracks appearing.
Yeah.
Here we go. The next.
Yeah, nicely fractured.
We have Dr. Jalisi with us as well as Dr. Najib Azam. Dr. Jalisi, do you want to say anything about the case? How would you have done it, or would you have done anything different?
You can see the cracks again. Yeah.
Your mic is not open, Dr. Jalisi. I think you need to
Sure.
unmute yourself.
Hi, I'm sorry I'm joining it late, but I think the question I had was there are cracks in that calcium, but obviously not enough. I think that's leading to not an optimal dilation.
I think what we have done actually, we have analyzed the depth of the cracks actually on OCT. I think there are about 10 of those cases which we are actually preparing at the moment. There is a lot of variation in the depth of cracks when you actually observe an OCT. We have, in fact, one of the most difficult area where IVL is obviously still getting a lot of popularity as well as usage is the left main stem. We have just reported our experience, which is going to be published next week, of close to 100 left main IVL sort of cases. The problem with the depth of the cracks is that the depth of the cracks are pretty good in the native vessel. When it comes to ISR lesion, where there are about 2 layers of the stents, the depth of calcium is so much variable. That's why it is so important when you select the IVL balloon that you do 1-to-1. If it is a 3.5 vessel, you at least have to select the 3.5 balloon. And if you undersize IVL, the depth of the cracks are going to be smaller. I think that's what my understanding is.
Yes, I agree, Javed. I support your view because I have seen some cases where there is no visible cracks, but still it softens the calcium and you can dilate it.
No, I think, Afsar, you have raised a very, very valid point, and I think I'm also of the same opinion.
What about using cutting balloon after something like this? It makes the cracks a little bit more established, makes the planes a little bit more looser?
I think that's an interesting thought, and it's a good thought actually. But I don't know. I mean, how many people use cutting balloon after the IVL?
I think once you have enough calcium fractures, then the most important thing is to take an NC balloon, 1-to-1 size, dilate it, and look at it in 2 orthogonal views and make sure that it's fully expanded.
Absolutely.
And if that's the case, then you're ready to stent. I mean, I think, the fact that you fractured the calcium means this vessel, you've changed the compliance completely, and it's a great example.
I think now we could show you this angiogram, which is the NC 3.5. This is after the IVL, and that is fully expanded. However, this balloon will not travel slightly distal to the lesion. So we got another problem where, for example, I was thinking whether we have fully prepared the lesion, including both the proximal part of the lesion and the distal part of the lesion. I think at this stage, either we could have used another NC balloon, but we didn't think that that will facilitate the passage of the stent. And I think also it becomes a little bit more expensive. At this stage, for the distal part of the lesion, I decided to use a slightly smaller IVL balloon so that we can get it through. I think that's worked very well, and we managed to get a smaller second IVL balloon into the distal part of the lesion so that we should not have any problem when we put the stent in.
Javed, there's a comment from Dr. Osman Fahim.
Yeah, sure.
I'm not a big fan of CSI, but do the operators and the panelists think that CSI here would be helpful? Usually it doesn't lead to much instability in terms of hemodynamics, and you can start from the smaller distal vessel and go all the way back to the left main.
Sure.
Yeah, so no, I think CSI has its advantages and disadvantages. I think I like Rota because it's more of a front cutter. CSI has a nose cone that makes deliverability an issue. The same reason that CSI doesn't cause instability is the reason I don't use it as much. I don't think it ablates as much. So it's not as effective as Rota. So Rota causes more microembolization. But having said that, it's not unreasonable because of its eccentric action in something like this.
It gives you an option in terms of going from, because of the size mismatch. And then,
once you have an IVL result like this, I think the point that was made is that you've already got the cracks. You can make those cracks more established by using a non-compliant balloon and just stretch it open a bit.
Javed, if you don't mind, we have to go just for 2 minutes to Turkey to just see the last image, and we'll come back to you.
Absolutely. Absolutely. No problem. Thank you.
Thank you.
Thank you. So you're going to do osteal. Okay, that's fine, that's fine. No, that's a very good point actually, Bilal.
Dr. Khan, can you turn on your camera? We are with you now. Dr. Hakan, can you hear us?
Yes.
Yeah, can you turn on your camera so that we can see you, like you and show us the images? We are with you now. You can quickly show us, please. Okay, go ahead, please. You have like 2 minutes to show us what you have done, then we'll go back to UK, please.
Görüntü alalım. Yes, can you hear me?
Yeah, we can hear you. Please go ahead quickly.
Yes, we performed the Rota Pro rotational atherectomy. I will show images. Then we take IVUS images also. I would like to show them. Bir görüntü alalım.
Go ahead, you have 2 minutes.
Please wait. Yes, this is the last images. No, before, please Rota. Yeah. Next. Rota images. No. Next. Yes.
So it seems like your wire came out, is that?
Later. Yeah. This is the after Rota. Yes, this is after Rota. Guide wire got back. Then we did IVUS. I would like to show the IVUS images. Please show the IVUS. IVUS'u gösterelim. This is the IVUS images after Rota and NC balloon. After IVUS, we performed the NC balloon 2.550 millimeter. IVUS.
Yeah, we can see some cracks there.
Can you see the IVUS images?
Yes, we can.
You can see now, yeah. There is also a deep calcification, as you see, circumferential calcification, and because of that, I performed another balloon, 3.15 millimeter. And yes, start. Go on. Okay. But mostly we correct the calcification, fracture calcification. Yeah, done. Is this one last images? Last images? Yes. Yeah, this is the 3.050 millimeter balloon. NC balloon. This is the last image before.
Okay.
Yeah, this is the last images after 3.050 millimeter NC balloon.
We can see the
now, I would like to.
Yeah, we are not
insert,
seeing your images, we are only seeing your IVUS.
Can you put the angio back on? We're seeing IVUS. We don't see those images you're showing us.
You would like to see IVUS again?
No. We can't get the IVUS off. That's all we see is IVUS.
We need to see the angio images now.
We don't see angio
images. Yeah, okay.
But again, would you consider cutting balloon? Again, I think it's a point I'd like to make that.
Maybe at that stage you can use the cutting balloon, but when we formed the NC balloon, we showed there is a good opening. Because of that, I think there is no need at that stage a cutting balloon or scoring balloon.
Dr. Khan, I think if you still have to, I thought you are finished. If you still have a work to do, we'll have to come back because we actually work with the UK. So do you have still to do stuff or you're done with the case?
Yes. After implantation, we will use the big size NC balloon, then we will take another IVUS images, then we will finish.
Okay, so we have to go back to UK. Well, I thought you were finished and you
Okay,
just wanted to show us the final images.
Okay, I will show you.
Yeah, we'll come back.
Yeah, please.
Hello?
Şöyle.
Okay.
Şöyle iyi.
All right, thanks.
Aç.
Yeah, Javed, we are back to you.
Oh, thank you. I think after using the second IVL, so we managed to put a longish stent from almost close to the ostium of the LAD into the proximal segment. Could we just show that, the stent?
Javed, can you put the NGO on the main screen? Can you ask them to put the NGO on the main screen and get
Can
Ivers
you
on the
put the
side
NGO on the
screen?
main screen, please? NGO on the main screen, yeah. So this is after 3-5, I think, longish stent. And obviously we have post-dilated it, and after that we have done another Ivers run. And I think...
Did you stent all the way to the ostial left main, or...?
No. I think we are just shy of the ostium. And we are just checking now, we are doing a pressure wire as well, just to make sure that there is no gradient drop in the ostium of the LAD, because we were definitely not planning to do anything to the left main, because obviously there's a good cross-sectional area of the left main, because the short left main and also the ostium. So that is the result. After the stent, we can put an IVUS, and we have actually post-dilated the stent with the 4O balloon with a stent boost, yeah. Can you see the IVUS on the screen?
Yes, we can.
Okay. I think with the current tools, the lesion modification has become a very important, and also we got number of tools compared to what we had about 10 years ago. So you could see that stent is reasonably well expanded.
This was the 3.0 stent?
3.5.
3.5.
Sorry, 3.0.
3.0.
My apologies. But we post-dilated it with the 3.5, and so here it is slightly underexpanded.
Yep.
So the FFR it's on the ostium is coming up to about 92, 94. There we go. So now that's coming up to the left main.
Yeah.
So would you suggest we do any further dilatation here, or any other suggestion from the panel?
I mean, I would still try a 4.0 balloon. I mean, it doesn't have to be non-compliant. You can maybe try a compliant 4.0 at high pressure, because those
I think we have tried 4.0, yeah.
Yeah, because there are
I
some
think
areas which are...
That area where it's underexpanded, I think you need to go maybe post-dilate that spot. That one small section looks quite underexpanded.
So we will take another balloon and do a little bit more high pressure dilatation, and then another IVUS. We will run another IVUS to see if that we have achieved that desired cross-sectional area.
Right. I think the other thing is, when you look at IVUS, you're looking at the distal stent edge. That looks beautiful. You look at the stent apposition. You're going to do some work there. You look at the proximal stent edge, and that looks really good too. And the nice thing is that even though there is disease at the ostium of the LAD, it's not critical. And you've shown it by IVUS and you've shown it by FFR. or IFR. So I think at this point, post-dilate, and if the flow looks good, I think you're done for now.
Yeah, I think the problem with the calcified lesion is, sometimes you have to modify your technique as you go along, and how the lesion evolves, how the patient tolerates it, you see. I mean, nowadays there are a number of sort of devices available, like IVL, rotablator, orbital atherectomy, laser, and then obviously cutting balloons, you see. And a combination of any of those, you see, that is usually brings more success of the procedure.
Correct, and I think you're right that even though we try to save costs, sometimes you do have to do combination, rotatripsy or rotacut or tripsy cut, all those things. But the nice thing is you have a nice big septal now to do retrograde for the RCA in the future.
That's right. I think that's a good point, in fact, you see. I think, obviously, I don't think that this gentleman would be ever suitable for surgical revascularization because of some of the other issues, you see.
Yeah.
And but hopefully, the most important thing would be that if he gets rid of a typical exertional angina, which he gets from just walking close to 100 yards. So we are just doing some further work in the stent just to post-dilate it further. So is there anything else panel thinks that we should be doing with this lesion?
Maybe I'll ask some of the other panelists. Maybe Dr.
I think that if you take a 4-0 balloon, go very high pressure, and you have a good stent area, even if there's a little bit of malapposition, you're okay. The data shows that acute malapposition is not related to outcomes per se. So the result looks really good.
No, thank you very much.
I think I agree with that. I'm just curious, how are you keeping your anticoagulation right now?
Yeah, I think we started with 8,000 heparin, and then we gave another 3, so it was almost 11,000. And what is the ACT? The last one was around close to 200, then we gave another 3,000.
Dr. Simor, Dr. Farhan Tayyib, anything else you want to add to? Dr. Tai, Dr. Tarek?
Very well done case.
I think so, very well done case, and I think just using a bigger balloon to expand the portion which is under expanded, I think that's the only thing that needs to be done. Otherwise, it.
I think that's exactly what we are doing, using a slightly bigger balloon at a slightly higher pressure, and hopefully, and that will result into some form of a good angiographic result at the end.
Thank you. I think we're going to try and go back to Turkey then, if we are done.
And we can show you the last angiogram after this initial dilatation very quickly before you go, so that here we go. So we are just about to.
Yeah. Maybe seat the guide a bit.
There we go.
Nice picture. Yeah.
Yeah. Okay. Yeah. So this is the final result.
We can't see it. It's the camera's cut out.
Oh, could we just show the results, please? Yeah. Okay.
Can you turn your camera on, please?
Can you show the last image? Yeah.
No, but Dr. Javed had the last images. He's showing the last images right now.
I think they've turned the camera screen.
So these are the last images.
Sorry, Dr. Javed, we can't see them because I think they're in the process of changing over to the other side. But
okay.
But maybe you can send them to Dr. Hanif. We can post. Oh, there now we can see them. Yes, yes.
Yeah, you can see them. Yeah.
Wonderful. Look at all the blush.
Thank you very much.
Congratulations. Now the EKG still shows ST depression. I was looking at the EKG
Yeah,
throughout.
I think it was the same we started with.
Yeah. Very nice.
Okay, thank you very much. We are grateful for giving us an opportunity to present a live case, and along with my colleagues, and it is a wonderful conference. We are delighted to participate into this.
Thank you very much for taking time out and doing the case for us. Very educational and obviously Probably one of the rare commodities that we don't have available in Pakistan right now is IVL. So it's, I think, great for the audience to get a first-hand experience of what it's like to use it. Okay, we can move to Turkey then. Turkey,
I'm going to switch your camera on for a minute, okay? I'm going to switch your camera on.
Yes. Dr. Hakan, can you turn your camera on, please? Dr. Najib, would you like to comment on the case?
Yeah, I think Javed has done very well, and I personally believe now IVL or shockwave balloon should be part of the most of the cath labs. It's a very safe technology. Whenever it's needed, really, it saves you, saves your patient, and saves the complications. And it's very simple to use. We do use reasonably very often, but I think if you don't have it in Pakistan, you should try to get it. It's much easier, much safer than rotablator, and a lot of time you can really deal your complex patients, complex lesion easily with the IVL.
Okay, thank you very much. I think both the cases were excellent. Dr. Asad had to go to another session. So we are going to end this session and start the new session. So thank you very much to all the panelists online as well as physically who are here. I would request Dr. Amber Malik to come and start the next session, please.
Thank you very much, Dr. Bashirini, for handing over. We have an excellent panel coming up. If I can request our panelists to come up. This is session number 4, and it is Interventional Cardiology Updates 2023. So we're going to have some back-to-back talks, so bear with us. These are going to be good talks. Dr. Mohammed Sarwar, if you are here, please come up to the panel as panelists. Dr. Bilal Mohiuddin, Dr. Javed Syal, Dr. Ahmed Numan, Dr. Sohail Khan, Dr. Abdul Rashid, Dr. Abid Ullah, Dr. Mujib Ullah. So if the rest of the panelists are not here, may I request some of our senior members and people who would like to be more interactive to come up onto the stage. I will also introduce our international panel. We have Dr. Tariq Shahab from USA. He is there.
Yes.
Yes, there he is. Dr. Farooq Jalisi. Is he here? Dr.
Yes,
Javed, yes, he is. Dr. Javed Suleiman from USA again. If he can acknowledge he's being there. Dr. Khurram Mia, again from USA. Dr. Naeem Tahir Kheli, who is the Oklahoma heart person that we know very well. Naeem Tahir Kheli, are you there? And Dr. Hafizullah, who's our well-known cardiologist from Peshawar. So without much ado, I think the time is 10 minutes to 4, and we should start off with our first talk from Fahim Jafri, who's here with us. Fahim Jafri, I can see your picture. Hello.
I'm here, hello. They should have the recording of it, which I had sent in.